Welcome to the online hip and knee pain advisory clinic. So hopefully by the end of the presentation you'll understand what can cause your hip or knee pain, the possible impact this can have on health and function, how can you manage and improve your symptoms, and what are the treatment options based on the latest research. So we'll start off with the knee joint and then we move on to the hip. So your knee consists of three bones. We've got your femur, which is your thigh bone, the tibia and the fibula, so that makes up your shin. And these are attached together by four strong major ligaments. So we've got your cruciate ligaments and your collateral ligaments. So your knee itself is surrounded by a group of powerful muscles. So these are your quadricep muscles. So these are at the front of your thigh. The hamstrings, so these are at the back of your thigh. And the calf muscles, so these attach into the back of the knee as well. And these are responsible for everything that your knee does. So when we look at knee pain and how it affects us in the UK, we know that nearly 40% of people over 50 have some form of knee pain. Nearly 20% of people over 45 have some form of knee osteoarthritis, and we know it reduces the quality of your life. So it can affect your ability to care for family or cause relationship strains with family and friends, and we get pain that's related to stress and anxiety as well. So when we look at knee pain that's occurred without injury, so there's not been a trauma or an accident to cause it, we're looking at how age can affect the knee in a predictable way. So it's like finding a grey hair or a wrinkle. And ultimately you get a reduction in the strength in the muscles, tendons and cartilage. And this affects your ability to manage normal day-to-day activities, so you get a slow reduction in resilience. So common conditions that we see, we tend to find there's different names for the same issues. So we've got knee osteoarthritis, degenerative meniscal tears and patellofemoral pain syndrome. So a lot of these are commonly known as wear and tear. So we'll start off with knee osteoarthritis. So this is usually due to age, injury or obesity. And essentially the smooth cartilage becomes rough and it makes it more difficult to move, leading to pain and stiffness. Now, when the cartilage roughens, the tendons and ligaments have to work harder, and you can find that you get some swelling or formation of bony spurs. So then we'll move on to degenerative meniscal tears. So this is the C-shaped shock absorber at the knee joint. It occurs without injury. It might be worse after a slight twist or kneeling. It's due to aging, but not old age. It's more common in men than women. It could be more common in your 30s or 40s, and if you've had it x-rayed, you'll find that it might come back as normal. And the key thing with this is that your knee is not locking. And finally, we've got patellofemoral pain syndrome. So this is pain that comes from a number of structures around the kneecap or patella. This is more common in women than men. It's common in people who kneel a lot, and it's usually referred to as runner's knee or jumper's knee. So in sports people, it's commonly caused by periods of intense activity or a change in training, and it can be common in obesity as well. So what we've done is we've put together a group of common symptoms for each of these conditions, and you'll find that a lot of them cross over. So when we look at knee osteoarthritis or degenerative meniscal changes, both of these will give you pain on the inside of the knee. You might have difficulty walking long distances, tenderness at the joint when you touch it, pain on kneeling, and pain that flares up and settles back down again. And on the right there we've got patellofemoral pain syndrome. So this can be worse with pain on kneeling, or you get pain on kneeling. You can get pain on stairs or walking uphill. Your pain can be worse when you drive or sit for long periods of time. And you might get pain that makes your knee give. And again, as with the others, you get pain that sort of flares up and then settles back down again. So when we're looking at treatment, the first part of that would be understanding why you have pain, and that's why I sort of put together this education. So if you understand the knee and the common conditions, you can look at other options or modifying activity to try and help your flare-up. So with this, we're looking at how can we reduce that. That might be looking at good pain relief. It might be physio, so exercises or any manual therapy. And essentially we're trying to maintain and improve the health of the joint. So we're trying to counteract those grey hairs and wrinkles that we find. So one of the common questions we get asked is, how long is it going to take to get better? So aiming to manage your joints again so they can cope with your normal life usually can take up to 2 to 3 months. And part of recovering and improving is understanding why you have pain. And that might involve making changes to your life and understanding that undergoing treatment can take time. Now, lots of people have a baseline pain, so they might have a dull ache that's in the background and it's flared up recently. And that might be due to you've done something slightly different. And this can sort of take 6 to 8 weeks to calm back down again, providing you're using the right methods that we're just about to talk about. So when we follow the what we call the NICE guidelines, so these are guidelines that are being put together by the National Institute for Health and Care Excellence. So anybody who works in healthcare who deals with an arthritic joint should be following these guidelines. So looking at sort of managing the flare-ups that we spoke about and that chronic pain, we should be looking at, one, getting lots of good information and advice. We should be looking at weight loss and modifying activity, using simple painkillers and trying to increase general activity. And then we'll look at the role of sleep as well. And then the next step there, we've got education sessions and physiotherapy. So that's where we're at now, providing education and understanding to these conditions and hopefully providing you with some rehabilitation that you can be working on. So the next stage then would be looking at corticosteroid injections. So some of you may have heard of those before. And then looking at how psychological input can also help pain. And then the last option for an arthritic joint would be surgery. So in this instance, it would be replacement surgery. So what we've done is we've put together a couple of articles that we've seen in the papers or online, and we get lots of questions about these. So the article on the left is about arthroscopies. Some of you may have heard of them. Some people refer to them as washouts. So when we look at the article on the left, it says how keyhole knee surgery for arthritis pain is pointless. And we do address that because we get lots of people saying, oh, I've had a washout in the past for my knee and it was really useful. Now, we've brought this to the attention because actually this procedure is no longer done in the UK. A really big study was done where they compared a group of people who had an arthroscopy, so a washout for a knee that had an arthritic change. And they compared this to a large group of people who had what we call conservative measures, so exercise and used regular pain relief. And when they looked at the outcomes, so short and long term, they found that surgery was no better than conservative measures, so physiotherapy, exercise, and using regular pain relief. So arthroscopies in the UK are no longer done for a degenerative or an arthritic knee joint. So the next study is long distance running is good for your knee study claims. So that article in the Telegraph there, again, we get lots of people who come in and say, I've been told to avoid high impact, or I used to do a lot of running and I think that's what's caused me to have arthritis, or it's worn my joint away. And again, we're just trying to look at addressing that really, because as physios, we're trying to promote activity. So when we look at this article in more detail, 700 people over 20 years were compared. A group were marathon runners and they were compared to the general population. And what we found essentially was the marathon runners had less arthritic changes in their joints. So I think it was about 9% of people went on to develop an arthritic joint, opposed to 18% of the general population who weren't active. So that's really promising for us because we're trying to promote that people stay active, and actually doing these things, whether you go out for long walks or runs, isn't actually causing more damage to your joint. And then finally, the article on the right is about injections. So again, we get lots of questions about them, and essentially it's saying that cortisone injections for hip and knee pain are more dangerous than once thought. And that comes down to people who've had perhaps repeated injections, or they have pain that doesn't seem to correlate with an x-ray. And what it does, it can actually speed up the wear process. So as a physio service, we have to be really careful and understand when an injection is really appropriate and useful. And actually, if it's not appropriate or we don't think it will help your condition, we have to be mindful that administering an injection can actually speed up the wear process. So we'll move on to the hip joint. The hip itself consists of the pelvis, and we've got a ball and socket joint. So this is your hip. So this is made up of the acetabulum, so the socket, and the head of femur. So this is what we call the ball. Now your hip again is surrounded by a large group of powerful muscles, just like any joint. So these are your gluteal muscles, and then we've got your hip flexor muscles as well. And again, as with any joint, the muscles around there control everything that we do, and they help take the force of the joint. So when we look at hip pain and how it affects us in the UK, we know that it can affect 1 in 9 adults over the age of 45, and it can, again, reduce the quality of life. It can affect your ability to care for family or cause relationship strains, and we know that we get pain that's associated with stress and anxiety. So when we look at hip pain without injury, so you've not had trauma or an accident, we're looking at finding those grey hairs and wrinkles. So age can affect the hip in a predictable way. And what you find is you get reduced strength in the muscles, tendons and cartilage. Again, with any arthritic joint, we're then looking at a reduction in your ability to manage your normal day-to-day activities. So you get that slow reduction in resilience. So common hip pain conditions that we see, we've got hip osteoarthritis, and so that might be known as wear and tear to most people, or greater trochanteric pain syndrome, and we'll just touch on both of those. So hip osteoarthritis, symptoms can vary greatly from person to person, but it can typically cause mild inflammation of the tissues in and around the hip joint, irritation and roughening to the cartilage, so that smooth shock absorber that lines the bones, and it leads to pain and stiffness or difficulty doing certain activities, so that might be getting in and out of the car or putting your shoes and socks on. So when we move on to greater trochanteric pain syndrome, so we'll call that GTPS for short because it's quite a mouthful. You might know of this as being called bursitis or tendonitis, and in some cases it's called gluteal tendinopathy. Now, essentially GTPS encompasses both a tendon and a bursa issue. So a bursa is the fluid sac, and actually what we call it doesn't matter because the treatment and the management are the same. So GTPS would give you pain at this side of the hip, and it can ache down the side of your leg, so usually down the side of the thigh into the knee. So this is related to changes in the health of the tendons that join the gluteal muscles, so your buttock muscles, to the hip, and sometimes of the nearby fluid sac, so the bursa. And the idea of this is that it reduces friction between tendons and bones. So poor postures and movement patterns over a period of time, changes in weight, changes in hormones can all contribute to reduced tendon health. So when we look at symptoms of both conditions, if we start with an arthritic hip, so you might find you get pain in your groin, your thigh, or in the buttock. You might get pain when you stand up from sitting, pain when you lay on your side, pain when you do anything for too long, so whether you stand or walk, or whether you sit for too long. You might have stiffness with your first few steps in the morning, and pain and stiffness when you flex the hip, so again, when you're putting your shoes and socks on or getting in and out of the car. So with GTPS, we're looking at pain over the bumpy bit at the side of your hip. You might have pain when you stand up from sitting, and pain when you lay on your side, so again, quite similar to an arthritic hip. With this, you tend to find you get pain walking uphill or on stairs, and you get discomfort when you sit in low chairs, especially if you cross your legs. And again, with this, as with any tendon issue, you would get pain on pressing the outside of the hip or the bony area at the outside of your hip. So looking at treatment and management, again, we're looking at education, so understanding why you've got the problem and trying to modify your activity. We're looking at using regular pain relief and being involved in physiotherapy, so exercising, stretching and strength work. And the idea is we're trying to maintain and improve the health of the joint, so we're trying to counteract those grey hair changes. So when we look at the role of injections in our treatment, injections are appropriate when we're trying to reduce a highly irritable or acute flare-up of symptoms. So it might be that you've tried ice, you've tried regular pain relief, you've tried resting and changing your activity, but you're still getting a lot of pain at rest, or your sleep might be affected. And an injection just essentially calms this flare-up down, so it then allows you to be involved with them and progress the rehabilitation. So if you've got a degenerative joint or an arthritic joint, repeated injections for these joints are not recommended. So as we spoke about earlier, it can actually cause a rapid progression of your degenerative changes. So medically we call this steroid arthropathy. So when we look at GTPS or bursitis, a large study was done. So high quality research has shown that when we compare education and exercise to people who decided to wait and see to an injection, we found that a large group of people who had education and exercise had better outcomes to people who decided to wait and see in short and long term. So at 12 months, if you decided to just see how you were, you'd have been better off having education and exercise. The next group was comparing education and exercise to a group that had an injection, and in the short and long term, education and exercise was superior. And essentially, an injection was found to be no more successful than wait and see in the long term. So one of the other questions we regularly get asked is, do I need a scan? So usually clinical assessment is often enough, so the signs and symptoms that you tell us. So x-rays and MRI scans aren't routinely required for the diagnosis of hip and knee pain. They can have some usefulness or utility in the management of a knee that keeps locking. And although scans can provide information, they don't often change the first part of your treatment for your hip and knee pain. And that's because findings on scans are very poorly linked to the amount of pain we have. So we found that findings on scans can be present in pain-free individuals. So what we've done is we've put a chart together looking at findings on knee MRI scans in those with and without knee pain. So the bit that we've circled here is that 25% of people who had an MRI scan had some form of meniscal changes. So they've called it a meniscal lesion here, so that might be a slight degenerative tear or wear change. And the interesting thing is that this group of people didn't have pain. So then we have to start looking at if you come into our clinic and you have knee pain and we scan your knee, if you have a meniscal lesion, does that mean it's the cause of your pain, or was it there anyway? So that's the confusion we get, and it doesn't actually change what we then do with you as part of a physiotherapy intervention. So looking at things you can do to try and help your problem, the first thing we talk about, as we've mentioned as we've gone along, is looking at modifying your activity. So that might be reducing factors that aggravate your symptoms. For example, with hip problems, it's useful to avoid crossing your legs or reposition items to a more convenient place. So if you know that you're repeatedly bending down to pick something up or you have to twist regularly, you put it in an easier place to access. If you know that you're on your feet for a long period of time, or you've got a day of gardening to do, it might be trying to break your activities into smaller chunks. So you regularly have a break or a drink to just break the activity up, or you spread out your activities that involve using your hip and your knee. The next bit is about rest. So in some cases we do need to have some relative rest or to try and reduce the load on your hip or knee. It's useful to try and avoid complete rest purely because we need to keep your joint moving, and that increases the strength around the joint and reduces stiffness. So another thing to consider is sleeping positions. So if your hip is uncomfortable, try laying on your non-painful hip and popping a pillow between your legs. Putting a pillow behind your back, may also stop you from rolling onto your painful hip during the night. And popping a pillow under your knee can also be comfortable, purely because the knee is under most tension when it's fully straight or fully bent. So just putting a pillow underneath the knee joint there stops it being in those positions. And then we look at ice or heat. So we get lots of questions around whether somebody should pop ice onto the joint or heat. Ultimately, it doesn't really matter. It's looking at what suits you and what's most useful. So don't apply either for more than 10 to 15 minutes at a time, and make sure you protect the skin by using a protective barrier such as a small towel. So using regular pain relief can mean that you can be involved in rehabilitation or you can do your normal activities. So we do recommend using something regularly as advised rather than as and when required. If you're not taking regular pain relief and you feel you need it, in the first instance, discuss it over the counter with a pharmacist, and they might be able to look at something that's not needing a prescription or you're not having to see a GP for. So if your pain isn't helped by over-the-counter medication, it might be worth speaking to your GP, particularly if you do have other medical problems. So other things when we start to look at lifestyle as a whole would be stopping smoking. So we know that smoking is linked to delayed and slowed healing. It contributes to poor tendon health and it increases joint pain. So stopping or reducing the amount that you smoke may help your problem and pain. So there is a link here that you can access, and hopefully that can provide you with information on stopping smoking, or pop into your local GP practice where they usually have stopping smoking services. So the next one's weight loss, and that's because losing weight doesn't just reduce the load that goes through your joint. The fat cells we have aren't dormant, so they are active. They influence the health of the joint and they increase inflammation. So if we can reduce our weight, not only are we reducing the force through the joint, but we're also reducing the inflammation in our body and then reducing pain. So as a physio service, we promote physical activity. So if you don't do much physical activity or exercise at the minute, try and gradually build something into your weekly routine. So preferably something that you enjoy doing, and it doesn't have to be hip or knee focused. So if we look at the guidelines we have here, we should be looking at doing 150 minutes of moderate exercise a week. So if you try and break that down, that would be 30 minutes 5 times a week, and that might be walking, cycling or swimming. If you wanted to do something more vigorous, it might be running, sport or taking the stairs. But I think the key to it is looking at how it fits into your lifestyle. So for some people, it might just be getting off the bus stop earlier and walking that bit further. For somebody else, it might be taking the stairs. Ultimately, there'll be lots of different levels of activity or fitness that somebody has, and we're trying to look at how it adapts and fits into your lifestyle. So what can we change? And I think, like I say, that the key is it doesn't have to be hip or knee focused. So everyone's journey or recovery looks slightly different, so be patient with yourself. It might take a little time to see improvements in your symptoms, and it's normal for your symptoms to vary from day to day, and this can be influenced by a number of factors. So try and compare your symptoms week by week rather than day by day. So small changes can make a really big difference. So other factors to consider would be stress, anxiety or mood, and that's purely because it's our nervous system that tells us when we're in pain. So if our nervous system is already working on a higher level because of our mood, we know that it can then heighten the pain experience. We also then look at how sleep can affect us. So sleep's important for recovery, but if we're not sleeping, we tend to find that we wake up perhaps more irritable. It can then affect mood. And if we're then not sleeping and have a change in our mood, we're also then influencing our pain levels. So we're trying to address the bigger picture, looking at reducing pain before you sleep, so pain relief, ice and sleeping positions. So then you're getting good amounts of sleep. And in turn, this can help your mood. So we're trying to look at addressing different factors. It might be that you need to look at addressing stress or anxiety so you're sleeping better. So whether that's looking at mindfulness or ways to relax before bed, it might be you see a GP about talking therapies or using appropriate medication to manage mood. And then in turn, if you're improving your mood, it can improve sleep. So essentially there's a cycle there, and we're trying to make sure that each aspect is being addressed. And then finally, if you found something that works for your hip or knee pain, so if you have a routine or something that you found that's really useful to just take the edge off your symptoms, keep doing it. There isn't any right or wrong. So in terms of exercise and rehabilitation, everyone's different and some exercises will work for you whilst others might not. So we tend to say do more of what feels good. Find a baseline or your current level of what you're currently able to do and try and gradually do a little bit more. So little and often is better in the early stages, As the exercises get harder or more challenging, you can reduce the amount that you're doing so you're allowing recovery time. A bit like if you went to the gym, you wouldn't do the same exercise every day. You'd change it, you'd have a recovery day. And we've put together a traffic light system, so hopefully that guides the intensity of your exercise or whether you should reduce or increase the amount that you're doing. So if your pain levels are 0 to 3 out of 10 and your symptoms settle quickly or immediately after exercise, we call this a safe zone. So you can potentially push yourself a little bit more, but you certainly don't want to be doing any less. If your symptoms are 4 to 5 out of 10 and your pain settles within a few hours, that's acceptable, but we wouldn't want to look at pushing you anymore. Now, if your pain levels go to more than 6 out of 10 and they stay that way for a few hours or into the next day, you're potentially, one, doing too much and we need to reduce that. Or it might be we need to change how you're doing the exercise. It might just be that it's one exercise that's aggravating your symptoms and you might want to stop that, but do more of the others that feel good or don't put you into that excessive category. So finally, other questions we get asked. So what activities can I do? Can I play sport? Can I drive? I think it's really key to know that despite pain or movement restriction, it's not dangerous to move your joint and it's unlikely to cause more damage or harm. So keep moving and participate in leisure activities or go to work where possible and try and modify your activity if it's painful. We say do more of the pain-free or tolerable activities and do less of the painful activity. So trying to summarise all of that then, we know that hip and knee problems are very common. We know that arthritic joints can be well managed and we can settle flare-ups. Any tendon problems can fully recover following rehabilitation, and in the meantime it can help to modify your activities and use pain relief. And again, we're looking at trying to remain or generally increase activity levels. So if your hip or knee pain doesn't improve as expected, please self-refer online. So we've put together a group of exercises to try and help the muscles that surround your joints and improve your function. We've put these together as links on the web page, so I hope you find those useful. If you have any problems understanding those or you want a little bit more guidance, again, please self-refer online.